Good afternoon, ladies and gentlemen. Let's talk about hematological complications in pregnancy. Before that, I'd like to declare that I've got no conflict of interest in this talk. Ladies and gentlemen, in the next 30 minutes, I'm going to talk about some common hematological complications and the principles of care. And I'm going to talk about anemia and hemoglobinopathies. The importance of not just checking the Rhesus blood group, but the importance of checking some common antibodies in pregnancy. Management of thrombocytopenia, and one important significant thrombocytopenia in the neonatal period known as neonatal alloimmune thrombocytopenia. I'm going to talk about hemolysis, the importance of MAHA, which is known as microangiopathic haemolytic anemias, the 6 common causes that all obstetricians must know. I'm going to talk about bleeding disorders, some updates about DIC, and finally, the management of hematological malignancies in pregnancy. So, ladies and gentlemen, I for one believe that hematological complications in pregnancy are not rare. They are far more common than what we think it is. In fact, I would say it is the most common medical disorder in pregnancy. However, despite being common, some of these may have significant maternal and fetal implications. And thus, ladies and gentlemen, it does not belong to the subspecialty of obstetric medicine. I believe that every single obstetrician should be proficient in management of hematological complications in pregnancy. Now, the moment you mention hematology, it is often not uncommon that we refer to the hematologist. But I believe most conditions in pregnancy, it is beyond the hematologist. What is important? We need a multi-professional team. We need to involve the neonatologist. We need to involve the transfusion medicine specialist. And please do not forget your good friend, the obstetric anesthetist. And these are the teams who are required to provide a holistic approach in management of patients with hematological complications in pregnancy. So, ladies and gentlemen, let's move forward to the most common hematological complication in pregnancy, iron deficiency anemia. Now, how frequent should you check a full blood count in pregnancy? It remains controversial, but at a minimum, the recommendation is to universally screen everyone on 2 occasions, one at booking and one at 28 weeks. Now, although iron deficiency anemia is the commonest cause, please do not assume that it is the cause for anemia. My recommendation is to investigate holistically. The most sensitive indicator for iron deficiency anemia is a mother with a low MCHC. There's going to be one test that you're going to do to confirm the diagnosis is a serum ferritin level, where ferritin level of below 30 is highly suggestive of iron deficiency anemia. Now, ladies and gentlemen, some of you all may do various other biomarkers, but I would like to remind you all one thing. None of the other biomarkers have ever been validated in pregnancy. So let's be cost effective. Let's perform and practice an evidence-based medicine. Low MCHC, send a ferritin level. If it's below 30, you confirm the diagnosis of iron deficiency anemia. Now, do you need to check serum ferritin level in everyone? Please be mindful that it may falsely be elevated in an acute phase of an illness, or especially if the patient has got an infection. But perhaps in most instances, you may give a 2 to 3 week diagnostic trial of iron supplements and recheck for response at least 2 to 3 weeks later. If the hemoglobin improves, you may be correct most of the time. However, ladies and gentlemen, there is no evidence to provide routine prophylaxis of iron supplements for every single pregnant mother. The evidence is clear. There's only evidence and there's only benefit to provide empirical iron supplements for high-risk group of mothers. Mothers who are obese, mothers who have got multiple pregnancies, they might benefit from empirical iron, not routinely for every single mother. The dosage of iron is 40 to 80 milligrams of elemental iron. Now, ladies and gentlemen, with regards to management of iron deficiency anemia, I would like to highlight one important recent evidence which suggests that intermittent oral supplementation is far better better tolerated, it's far effective as compared to continuous iron supplementation in pregnancy. So if you have a high-risk mother, if you have an anemic mother, if she cannot tolerate iron, it is okay to give her intermittent iron supplementations 2 to 3 times a week as compared to a continuous approach. There's only one indication for parenteral iron, and I believe if the mother is unable to tolerate oral iron. So please remember, use the oral route first. If she's unable to tolerate, then consider parenteral iron. But before giving parenteral iron, confirm the diagnosis of iron deficiency anemia, ensure that the ferritin levels are below 30. There are various medications which are available for parenteral route. The newer medications have got higher doses compared to the older doses and types of medications. I'd like to bring your attention to this wonderful guideline which was just published 2 years ago on the UK guidelines in management of iron deficiency anemia in pregnancy. Let's next move on to B12 and folate anemia. So ladies and gentlemen, B12 and folate are not as common as iron deficiency anemia, but think about B12 deficiency, especially if the patient has had a bariatric surgery, the patient has got Crohn's disease, or if you suspect the patient to have aplastic anemia. Although the MCV may be higher than 115, although a full blood picture may be suggestive, it is important to check the serum B12 level or a folate level to confirm the diagnosis. And serum B12 levels of below 250, although it is within a normal range, has to be treated for reduction in maternal and fetal implications of harm. So serum B12, keep it above 250. Check if you think the patient has got risk factors for B12 deficiencies. So ladies and gentlemen, having covered iron deficiency anemia, let's move on to a more important anemia, cause for anemia in these parts of the world, known as haemoglobinopathies. So if you have a patient who is of Caucasian in origin, or if you've got a patient who's on African in descent, think of sickle cell, universally screen for haemoglobinopathies, especially sickle cell. Why? The patient is a sickle cell carrier, or the patient does have a sickle cell major. The patient stands a high chance of having acute painful crisis during pregnancy or acute chest syndrome. The RCOG Green Top guidelines have got a wonderful guidelines about management of sickle cell in pregnancy, but it's important to screen for pulmonary hypertension, screen for retinopathy, renal and liver involvement, and all of these patients will benefit from a multidisciplinary care. But please do not forget your aspirin. Please do not forget your penicillin prophylaxis. But coming back to this part of the world, ladies and gentlemen, now the incidence of thalassemia among couples in Malaysia is 1 in 30. So it's important that you make sure that you do not exclude or do not miss a patient with thalassemia who's pregnant. If you have a thalassemic patient, it's important to screen for iron overload, a point of which I shall highlight again in the next slide. A simple bedside tool that you can use to risk stratify your patients is to use a Menzies index. Now, the Menzies index is the index of MCV against RBC. In thalassemic patients, your MCV will be low, your RBCs will be high, and so a ratio of below 30 is suggestive of thalassemia. You can do a confirmatory test, which is clinically indicated. And please ensure you have ruled out thalassemia, especially among anemic pregnant mothers in Malaysia or among Asians. So how do you manage beta thalassemia major in pregnancy? First, confirm the diagnosis. Second, check the partner's status. If both of them are carriers, they've got a 25% chance of having an infant with beta thalassemia major. It is not a lethal condition as compared to alpha thalassemia, but ladies and gentlemen, that baby later on, that infant may have significant needs with regards to frequent blood transfusions. So if you have a couple who are both carriers, refer to the fetal medicine unit. Pre-pregnancy, you may offer a pre-implantation genetic diagnosis followed by an IVF. That is one option. Or if they are pregnant, they can either have a CVS or an amniocentesis to confirm the status of the baby, 25% normal, 50% carrier state, or 25% major. Apart from that, if the pregnant mother is pregnant and has required frequent blood transfusions, screen for hepatitis, screen for HIV, and give them phenotype-specific blood. Although most guidelines recommend a hemoglobin count of above 10, I believe it is important to have an individualized approach. The pregnant mother is completely well. The pregnant mother is asymptomatic. She's got no other concurrent risk factors. If she's got no IUGR, it's okay to have a range of between 8 to 10 in pregnancy. However, the pregnant mother has got hepatosplenomegaly. If she's got other concurrent risk factors like cardiac diseases, or if she's symptomatic, or if she's got IUGR, then you can aim for a higher level. Now, ladies and gentlemen, don't just do an ECG. Don't just do an echocardiogram. These are non-sensitive tools to diagnose cardiac overload. The one sensitive test is to do a T2 weighted MRI. Now, T2 weighted MRI is not contraindicated in pregnancy, but remains the gold standard to diagnose liver or cardiac iron overload. So if you suspect iron overload, if the serum ferritin is high, the level of thousands, ensure the mother ideally has had a cardiac or a liver MRI in the pre-pregnancy state, or it is okay to do it in the pregnancy state. Now, why is that so? Iron overload can easily be treated in pregnancy with iron chelation agents, namely deferoxamine. It is not contraindicated in pregnancy. Now, some older studies have showed that deferoxamine is associated with gastrocrisis, but these are all older studies. It can be safely be administered in the second trimester. So, ladies and gentlemen, think of iron overload, screen for iron overload. It can be treated in pregnancy. Apart from screening for iron overload, you can also screen for diabetes, screen for thyroid diseases, and vitamin D3 deficiencies. If the mother has got significant hepatosplenomegaly, take a look at the platelets, ensure the mother does not have portal hypertension. If an ultrasound shows there is evidence of portal hypertension, she will benefit from an OGDS. Now, an OGDS is not contraindicated in pregnancy. It's far more beneficial as compared to the risk. You should look for esophageal varices, and this should be banned in pregnancy. So ideally, mothers with portal hypertension, you need surveillance of OGDS at least 6 weekly to 2 monthly, up to 28 weeks, and then 2 weekly from 28 to 34 weeks, and then weekly until delivery, because prophylactic banding will reduce complications in the mother. As mentioned earlier, the mother has got hepatosplenomegaly. The mother does have portal hypertension. A hypertransfusion protocol is preferred. Also look at the platelet count. If it's too low, think of portal hypertension. If it's too high, the mother has got a risk of thrombosis. And in such instances, the mother will benefit from aspirin plus low molecular weight heparin to reduce the incidence of thrombosis. They do need growth scans. They need to be followed up by a maternal medicine expert, ideally in an obstetric medicine clinic. And in mothers who have had a splenectomy, talk about vaccinations. Apart from the routine vaccinations of Tdap and influenza and COVID-19 in pregnancy, they need an additional 3 vaccines for asplenic patients, namely meningococcal, pneumococcal, and Hep B vaccinations. So now let's move on to red cell antibodies. Just like how we used to screen universally for anemia, I think it is also important to universally screen for red cell antibodies in pregnancy, not just once, but twice. Once at booking and once at 28 weeks. So ladies and gentlemen, why is that important? Because it's associated with fetal anemia, where the incidence of hydrops fetalis and hemolytic disease of the newborn is significantly high. So the mother does have and does give a history of anemia, hydrops fetalis, or hemolytic disease. Screen for red cell antibodies. Take a history. Was there presence of unexplained severe jaundice? Was there presence of fetal anemia in the previous pregnancies? look for fetal antibodies or maternal antibodies in this current pregnancy. The way forward, ladies and gentlemen, is to do a non-invasive prenatal fetal genotyping early on in the pregnancy. However, although I believe this is going to change the way we manage such patients in the antenatal period, as of now, the recommendation is to check the mother's antibodies not once, but twice. The mother has already been alloimmunized, then there's no benefit and no contraindication for invasive testing. Now, often, we are always engrossed with Rhesus anti-D levels. But I'd like to highlight, ladies and gentlemen, it is not just the anti-D which is important, but look at anti-C and anti-K. The mother has got antibodies, you should refer them to a tertiary center. It should be monitored and followed up in a fetal medicine unit. The antibody titers need to be checked 4 weekly up to 28 weeks and 2 weekly until delivery. Now, what are the titers of concern? If your anti-D titers are above 4, your risk of hemorrhagic disease of the newborn is moderate, they should be referred. If your anti-C levels are above 7.5, the risk of moderate hemorrhagic disease is high, they should be referred. Anti-K antibodies, irrespective of the titer, you can't check titers, they should be referred. And all these patients would benefit from 1 to 2 weekly of fetal middle cerebral artery Doppler, measuring the peak systolic velocimetry, looking into fetal anemias. They should be delivered in a tertiary center, check the cord blood for fetal anemia, liaise with your pediatricians, and you also need to have the input from a transfusion medicine specialist, because to provide mothers with this blood, group cross-match for these mothers is not going to be easy. So you need a multidisciplinary team, not just the hematologist, but also the neonatologist and a transfusion medicine specialist. Next, move on to everyone's favorite, management of Rhesus diseases. Ladies and gentlemen, I believe the way we're going to manage Rhesus diseases is going to change in a big way. The future is targeted prophylaxis, not routine prophylaxis. So the future, as early as 10 weeks in the pregnancy, you can do a non-invasive prenatal diagnosis using a real-time PCR to confirm the baby's blood group. If the baby's blood group is negative, the mother's blood group is negative, you do not need to give routine prophylaxis. But that is the future, ladies and gentlemen. As of now, we still recommend general prophylaxis. There are 2 methods of general prophylaxis. You can use the traditional 2-dose approach by giving someone 500 international units, one at 28 weeks and another at 34 weeks. Or option number 2, which is the newer approach, because you do not have the dosage of 500 easily available in most parts in Malaysia, you can use a higher dose of 1,500. Give it once between 28 to 30 weeks. Now, what is the reason that you need to give it between 28 to 30 weeks? This is when the lower part of the uterus forms, and this is the time when the mother has got a significant risk of developing antepartum hemorrhage. And that is why the recommendation is to give it between 28 to 30 weeks. The duration of protection of 1,500 is up to 12 weeks. However, ladies and gentlemen, it's always important to recheck the baby's blood group in the post-delivery period, is to quantify using a Clay-Hoyer's test. If the mother has got significant fetal metal hemorrhage, based on the volume of fetal metal hemorrhage, you need to give higher doses of anti-D thromboprophylaxis. As mentioned earlier, the mother already has got antibodies, then there's no role for prophylaxis. You need to check titers, you need to refer to a fetal medicine unit, you need to screen for anemia using MCV Dopplers, and you need to plan the delivery timely. So with that, ladies and gentlemen, let's move on to another common hematological complication in pregnancy, known as thrombocytopenia. Now, I'd like to highlight that it's important to investigate all causes of thrombocytopenia if the platelets are below 100. If it's above 100, it is of no concern in pregnancy, but below 100, you should think of investigation, you should monitor, you should look for a cause. Now, don't just assume it is gestational thrombocytopenia. It remains a diagnosis of exclusion. You need to exclude, you need to investigate, and then come to a diagnosis. Please do not assume it is gestational. Another common practice among obstetricians is to send a full blood count in a citrated bottle. So ladies and gentlemen, please do not routinely send a full blood count in a citrated bottle. You should only send when there's evidence of clumping, and hence it is important to establish the diagnosis. Send a full blood picture. If there's evidence of clumping, it is not a clinical diagnosis, but it's actually a laboratory diagnosis. And then you should send the sample in a citrated bottle. Now, another important point about thrombocytopenia, please do not be engrossed with the number of 50 or the number of 80. What I think is far more important is the quality of platelets rather than the quantity of platelets. So ladies and gentlemen, in most immune causes, immune-mediated thrombocytopenia or gestational thrombocytopenia, mothers usually do not bleed. A platelet number of 30 or a platelet number of 50 is sufficient. However, if it's an infective cause, then the degree of platelet dysfunction is far more severe. So the take-home message, don't be engrossed with the number, but look for a possible diagnosis. So what are the first few things you need to do to diagnose thrombocytopenia? Send a full blood picture. Look at the platelet morphology. Rule out hemolysis. Exclude MAHA, microangiopathic haemolytic anemia. And a full blood picture, which is the first line test, will also exclude the presence of platelet clumping. Next, look for an infective cause: hepatitis B, HIV, hepatitis C, dengue, COVID, or some of the infective causes you need to exclude. Send an ANA because you need to exclude a connective tissue cause, namely SLE, which may present with MAHA as well. And look for renal and liver function as well, because patients with liver cirrhosis may also present with thrombocytopenia. Now, if the count drops below 50, you may have a trial of steroids, all kinds of steroids, prednisolone, methylprednisolone, hydrocortisone are safe in pregnancy. The placental transfer is insignificant. However, it is important to avoid traumatic delivery. It's important to check the baby's cord blood, because 15% of mothers who are thrombocytopenia will have babies who are also thrombocytopenic. However, having had this systematic approach, having assumed it is not gestational thrombocytopenia, it's important to be cautious in certain circumstances of thrombocytopenia. Be cautious if it's an infective cause such as dengue or COVID. Be cautious if it's DIC. Be cautious if it's an abruption. Be cautious if it's an amniotic fluid embolism, because the degree of bleeding can be significant. And these are 4 instances of thrombocytopenia that you should be cautious of. So ladies and gentlemen, that moves on to the next topic of neonatal alloimmune thrombocytopenia. So if you have a patient who gives a history of the previous baby in a previous delivery has got mild to moderate thrombocytopenia, of the previous baby has got intracranial hemorrhage, think of a rare cause, but an easily treatable cause known as neonatal alloimmune thrombocytopenia. The way forward, you can offer NIPT, you can offer paternal testing, but it's not easily available in these parts of the world. Some part of the management algorithm recommends a CVS or an amniocentesis to confirm the status of the bleeding of the fetus. But however, ladies and gentlemen, it is not routinely done, and this may sometimes cause more harm than benefits, especially if the baby has got thrombocytopenia. The recommendation is to give the mother IVIG from 16 to 18 weeks onwards till delivery, and to deliver the baby via a traumatic way, ideally via a cesarean section. Now, interestingly, in the UK, they've embarked on a new project called PROFNATE project, where they are giving mothers immune prophylaxis, trying to reduce the incidence of neonatal alloimmune thrombocytopenia. And I think we should watch this space. But I'd like to bring your attention to this wonderful, newly published scientific impact paper on prenatal management of fetus with neonatal alloimmune thrombocytopenia. So think about it, have a degree of suspicion. If you think the baby has got neonatal alloimmune thrombocytopenia, giving the mothers IVIG is beneficial. Refer the patient to a fetal medicine unit. Moving next, ladies and gentlemen, hemolysis. Now, hemolysis in pregnancy is not uncommon, and the most common type of hemolysis is known as MAHA, also known as microangiopathic hemolytic anemia. Now, ladies and gentlemen, for the sake of simplicity, I would like to simplify 6 common causes of MAHA in pregnancy. The common cause is SLE, but most of these patients would already have had the diagnosis established. Patients with APS may also present with MAHA for the first time in pregnancy, but APS may also have got the diagnosis established. Now, what is easy for most obstetricians is HELLP or acute fatty liver in pregnancy. So patients with HELLP syndrome or patients with acute fatty liver in pregnancy traditionally present in the 3rd trimester. Traditionally, they do have high blood pressure and they do have significant liver impairment. But ladies and gentlemen, it is not always HELLP. It is not always acute fatty liver in pregnancy. It's important to look at 2 other causes of MAHA, which is TTP or HUS. Now, how do you differentiate TTP with HUS? The patient has got severe thrombocytopenia. The patient has got severe central nervous system manifestations. Think of TTP. ADAM13 is the pathognomonic test to clinch the diagnosis. The patient will benefit from a plasma exchange. On the other hand, if the thrombocytopenia is not severe, but the patient has got more severe renal manifestations, think of HUS. So renal plus thrombocytopenia is HUS. Severe thrombocytopenia plus CNS manifestations is TTP. And management of HUS is usually supportive. And ladies and gentlemen, please remember your 6 causes of MAHA in pregnancy. So moving on, I'm going to talk about some principles of care in patients with bleeding disorders. So the principles are, it's important to monitor levels before procedure or before delivery. It's important to confirm the gender of the fetus. It's important to confirm a prenatal diagnosis to see whether the fetus is involved. It's important to have a multidisciplinary team management, not just a hematologist, but also your transfusion medicine specialist and your neonatologist. I think you should be guided by assays, especially pre-delivery, not just blindly based on the diagnosis. And please remember, although most of your factors increase in pregnancy, they significantly drop post-delivery within 3 to 5 days. So you may have no PPH intrapartum, but they may manifest with PPH in the postpartum period. And these are some of the principles of management. So for the sake of simplicity, I would like to risk stratify patients into 4 groups. High risk group of patients. Now, which patients should you be concerned of? Patients with type 3-1 Willebrand's disease. Patients who are hemophilia carriers but have got a significant history of bleeding history. Platelets with platelet dysfunction, infective cause that I mentioned earlier, DIC, abruption, amniotic fluid embolism are patients who have got significant risk of bleeding, and patients with homozygous coagulopathies. Now, for the patients with moderate risk, patients with type 2-1 Willebrand's disease, patients with mildly reduced levels, namely level 8, factor 9, and 1 Willebrand activities, and patients with factor 9 deficiency. Most of other patients, provided you check levels, and if the levels are above 0.5 or the 1 Willebrand activity is above 0.5, usually they do very well. And other patients are unlikely to be at risk. So ladies and gentlemen, risk stratify your patients. Be cautious about patients who are high risk and patients who are moderate risk. So let's move on to the high risk group of patients. How do you manage patients with 1 Willebrand disease? Take a history, check a baseline level, and monitor factor 8 and 1 Willebrand ristocenin cofactor once again at 34 to 36 weeks. The levels should ideally be minimum above 0.5 international units per mil. the levels are low, you may manage them together with a multidisciplinary involvement of a hematologist. You can give them desmopressin. But desmopressin causes water intoxication. So please remember, you need to restrict fluids. You can also give 1 milligram concentrates. You can also give tranexamic acid in the intrapartum period, but most importantly, in the postnatal period. Now, please remember, ladies and gentlemen, for 1 milligram type 1, they do very well. 1 milligram type 2A, they do very well. 1 milligram type 2B, you may need to give platelets and 1 milligram factors. But patients type 3, you should be concerned. You should watch them slowly. The levels may drop significantly and may be low for 2 to 3 weeks post-delivery. You may need to give them factors and watch them closely up to 2 to 3 weeks post-delivery. Let's talk about hemophilia patients. Take a history. If you've got a hemophilia with a bleeding history, be concerned of the patient. Check the male status of the patient and ensure if the patient is a carrier or if the patient is affected. It's important, once again, to be guided by assays and check factor 8 and factor 9 levels. Once again, the magic number is 0.5 international units per mil. But unlike 1 milligram type 3, hemophilia levels reduces day 3 and day 5. And this is the important time when you should watch them closely and monitor them closely. You may give them antenatal desmopressin. You may give them recombinant factor 8 and factor 9. But what is important, although you may use tranexamic acid, watch them closely, have an individualized plan of care. They may bleed day 3 to day 5 in the postnatal period. So ladies and gentlemen, what about patients with DIC? So disseminated intravascular coagulopathy, I believe every obstetrician needs to be skilled in making the diagnosis of DIC. It remains a clinical diagnosis. If you have got a patient who is bleeding, please do not use the old recipe of 642. That is no longer practical. The current recommendation is to have a massive transfusion protocol using a ratio of 1 to 1 to 1. So ladies and gentlemen, early use of FFP have been proven to significantly reduce the need for other additional blood products. So the target is to keep the hemoglobin above 8. To keep the INR below 1.5, you can use early use of FFP. To keep the platelets above 50 if the patient is not bleeding, or above 75 if the patient is bleeding. But it's also important to check for fibrinogen levels. Now, all the studies showed that the fibrinogen levels should be above 1 gram. But ladies and gentlemen, a fibrinogen level of 1 gram, the patient has got a significant high risk of bleeding. It's important now to keep a fibrinogen level of above 2 grams. So what improves fibrinogen level is your cryoprecipitates. So use a ratio of 1 to 1 to 1. Make a clinical diagnosis. Early use of FFP. Keep your fibrinogen levels above 2 grams are some of the points. However, what is going to change the way we manage the IC is going to be a point of care testing. And this machine shows ROTEM, known as rotational thromboelastometry. It's a wonderful point of care testing, which I believe is going to change the way we manage patients who are DIC. On the other hand, the patient is clinically well. The patient has got no clinical signs. You can use a modified ISTH score to guide your need for blood and blood products. And there is a summary on how to manage a patient who has got DIC. Ladies and gentlemen, finally, I'm going to move on to the last part of the talk, hematological malignancies in pregnancy. Before I talk about hematological malignancies, let's talk about some diagnostic procedures which are safe in pregnancy. Yes, you can do a bone marrow. Yes, you can do a lymph node biopsy. Chest X-rays, high-resolution CT scans are not contraindicated in pregnancy. Having said that, ladies and gentlemen, the preferred modality is an MRI as compared to a CT scan. I'd like to highlight one fact: a CT scan is not absolutely contraindicated. The radiation from a CT scan is far below 50 milligauss, which is the toxic dose. You can do a CT scan if you think it's going to be beneficial to save the mother's lives. However, A PET scan or a FDG scan is usually not recommended in pregnancy, especially the first trimester. So these are your diagnostic modalities which are preferred in pregnancy. Can you give chemotherapy in pregnancy? Yes, ladies and gentlemen. Just like managing someone with breast cancer, you can give AVBD, you can use CVP, you can use CHOP regimes, and there are newer studies showing that methotrexate can be given in the third trimester, although generally we try to avoid them in pregnancy. So these regimes, ladies and gentlemen, are not contraindicated in pregnancy. So another commonly used favorite medication with regards to management of hematological malignancies in pregnancy is rituximab. So ladies and gentlemen, rituximab can be given in pregnancy. It is not contraindicated and it can be used in exceptional circumstances. I'd like to bring your attention to this wonderful paper by Mei Ching Su, who highlights the importance of biologics in patients who are pregnant, and it strongly establishes about the safety profile of rituximab in pregnancy. The recommendation is to stop it a few months before delivery. Breastfeeding is not contraindicated. So ladies and gentlemen, I'm going to move on and summarize about the management of lymphoma in pregnancy. So Hodgkin's lymphoma is the commonest type of lymphoma in pregnancy. The prognosis is good. Patients may present with shortness of breath, fatigue, night sweats, and sometimes they may have painless lymphadenopathy, especially cervical or submandibular axillary lesions. And sometimes they may have the nodular sclerosis is the most common type. With regards to non-Hodgkin's lymphoma, the prognosis is not as good as Hodgkin's lymphoma. They may present with diffuse large beta cell lymphomas. Sometimes it is associated with HIV. And patients with non-Hodgkin's lymphoma usually have got extranodal or involvement of the reproductive organs. And sometimes they may have aggressive large B cell type of non-Hodgkin's lymphoma. So once again, the principles of care: biopsy, image them, sufficiently stage them, and these are essential in management in pregnancy. You can give them AVBD regime, you can give rituximab. The CHOP regime is not contraindicated in pregnancy. And ladies and gentlemen, even localized radiotherapy for lymphomas are not contraindicated in pregnancy. So non-Hodgkin lymphoma, the aggressive B cell, be cautious. Hodgkin's lymphoma usually have a good prognosis. So management of Hodgkin's lymphoma, you need to know whether they are in the first trimester or second trimester. First trimester, early stage, wait till the second trimester. It is okay to delay treatment. But if they got an advanced stage early in the pregnancy, you need to talk about the benefits of continuation of the pregnancy. However, if they've got Hodgkin's lymphoma, they are in the second or third trimester, management is to treat with AVBD chemotherapy regime. The prognosis is usually good. On the other hand, if they have got a non-Hodgkin's lymphoma, namely a beta cell lymphoma or a follicular lymphoma or a Burkitt's lymphoma, you need to stage them in the pregnancy. You need to ensure you've got the right histological diagnosis. Next, you need to see whether this is an indolent type or whether it's an aggressive type. If it's an indolent type, it's okay to wait and watch in pregnancy. However, if it's an aggressive type, you should be concerned in pregnancy. Later in the pregnancy is to deliver and treat the mother effectively. Early in the pregnancy, deliver and treat the mother. Middle part of the pregnancy, you can give rituximab, you can give CHOP, but these mothers need to be managed closely. So moving on to leukemia. Now, acute myeloid leukemia is the commonest type of leukemia in pregnancy. CML and myelodysplastic syndromes are rare. Now, the presentation of acute myeloid leukemia is a hematological emergency. Patients may present with thrombosis, leukocytosis, and BIC. So be concerned if the patient presents with weight loss in pregnancy, bloating, and night sweats. It is not always tuberculosis. Medications such as interferon alpha are not contraindicated in pregnancy, although we generally avoid thyroxine kinase inhibitors. Myeloproliferative neoplasms may present with thrombotic events, especially if we have thrombosis in rare sites. Think of a myeloproliferative neoplasm. But ladies and gentlemen, while we speak, evidence with regards to targeted therapies, which has been the mainstay of management of leukemia in pregnancy, continues to evolve. And I believe in the next few years, we will be giving targeted therapies for pregnant mothers. But please do not forget thromboprophylaxis. Mothers with malignancies in pregnancy, namely leukemia, will benefit from thromboprophylaxis. So how do you manage acute myeloid leukemia or acute lymphocytic leukemia? Early pregnancy, we need to discuss about the risk and benefits of continuation of the pregnancy. Later in the pregnancy, the management is the same. Similarly, for acute lymphoblastic leukemia, early in the pregnancy, you need to talk about potential termination. Late in the pregnancy, you need to talk about the benefits of multi-drug chemotherapy. I think the goal of management of acute myeloid leukemia is ensure that the mother is given optimal treatment while you're ensuring that you have taken the fetus to a safe gestation where you can salvage the fetus without causing any significant harm to them. So finally, myeloproliferative and CML, they are rare, they are not uncommon. Interferon alpha is not contraindicated in pregnancy, but usually medications such as thyroxine kinase inhibitors are avoided, but think of thromboprophylaxis. So ladies and gentlemen, other hematological causes, think about vaccine-induced thrombotic thrombocytopenia, especially if the patient has got a vector-based vaccine. This is significant even up to 28 days from the first vaccine. Southeast Asia ovalocytosis is just as common as iron deficiency anemia, so it's important to stand a full blood pressure to look at the platelet morphology. If you've got a patient who have been given unfractionated heparin, think of heparin-induced thrombocytopenia. Although the platelet counts are above 100, if there has been a significant drop on patients on unfractionated heparin, think of HIT. You should monitor the platelet count 3 to 4 days until throughout the entire duration, the patient is on unfractionated heparin. The patient is on low molecular weight heparin. Please monitor the peak and the trough, especially if the patient has got prosthetic valves. Based on recent studies, if you monitor the peak alone, 50% of the time, the patients will have a subtherapeutic trough. So moving forward, there's also no role for routine coagulation profile prior to delivery or a routine coagulation profile prior to a patient in labor unless the patient has got a history of bleeding disorders. And please do not diagnose infection purely based on the WBC. The WBC is usually increased in pregnancy. Anything above 20 is considered significant. So to summarize my talk, ladies and gentlemen, anemia is common, but it is not always nutritional deficiencies. Do not always assume it is iron, but it's okay to have a 2 to 3 week diagnostic trial. In these parts of the world, screen for thalassemia, rule out haemoglobinopathies. Iron chelation is not contraindicated in pregnancy. Ladies and gentlemen, thrombocytopenia, don't assume it is gestational. The quality of the platelets is far more important than the quantity. Do not be engrossed with the number 50 or 80, establish a diagnosis. There are 6 common causes of MAHA in pregnancy: TTP, HUS, HELLP syndrome, acute fatty liver in pregnancy, APS and SLE are the common causes. Hematological malignancies, Hodgkin's lymphoma, CML have got good prognosis. Patients with non-Hodgkin's lymphoma or acute myeloid leukemia, they are of concerns. They need a high multidisciplinary care and close surveillance and monitoring. Hematological complications are not uncommon. Every single obstetrician should be proficient. You should be skilled in management of hematological complications in pregnancy. If you do need more information, kindly visit our website, Malaysian Obstetric Medicine website, or www.obstetricmedicine.my. We have got a lot of free resources for you and for your patients. And with that, ladies and gentlemen, thank you so much for your attention. And that ends my talk on hematological complications in pregnancy.